My name is Jeff Oxnard, and it's my pleasure to present on genome-wide sequencing for early lung cancer detection from plasma cell-free DNA, a report from the Circulating Cell-Free Genome Atlas study. Lung cancer screening, we know, has the potential to improve survival. A randomized trial has shown that CT-based screening improves outcomes, and yet CT-based lung cancer screening is not widely adopted. We know this from data, in fact, being presented at ASCO this year. Criticisms of low-dose CT include risk of false positives and overdiagnosis. Here, we propose to investigate an untapped opportunity for cancer detection, which is using cell-free DNA. This is not cancer genotyping, where you're looking in the blood for a key mutation and targeting that mutation. That's now standard in lung cancer care. This is cancer detection, and it requires a different approach. You have to look broadly across the entire genome, and it could address an unmet medical need. CCGA is a massive study. It is enrolling 15,000 individuals. 70% of them have cancer, untreated, and 30% of them are non-cancer subjects. To date, 12,000 have been enrolled across 142 active sites in the US and Canada, and this rapid enrollment, I think, is a marker of the enthusiasm for this kind of approach, both from patients and from providers. Here we are reporting upon 2,800 samples in a pre-specified case control study. These are divided into a training set and a test set, and of the evaluable and analyzable cases, we are left with 118 lung cancer cases and 561 non-cancer cases in the training set with an independent test set for validation. Importantly, the lung cancer and non-cancer participants are comparable with respect to age, race, and body mass index. As expected, the lung cancer individuals are more likely to be male and more likely to have smoked. But having a comparable control cohort is very important in the development of such a diagnostic for accurate analysis of the potential false positive rate. The sequencing in this effort is exhaustive. 3 parallel sequencing approaches are being used. A targeted sequencing approach, very deep, across 507 genes, and then 2 whole genome-wide approaches, whole genome sequencing and whole genome methylation analysis, both which, to my knowledge, have not previously been published on. Each of these allowing you to query for all major somatic and epigenetic features within the cell-free DNA. At the same time, the white blood cells are sequenced. That's very important. The white blood cells are rich with mutations, which can pollute the DNA and make you think that there's cancer present in the cell-free DNA, which is in fact shed from the white blood cells. You screen out this interference from the white blood cells and other biologic noise, and you're left with the final features: mutations, copy number variations, and methylation signatures, which then go into the final assays being studied. You can use this rich sequencing data set to think about different ways one could try to look for cancer present in the plasma DNA. For example, let's say you use an approach where you looked at one key region that is mutated in lung cancer, KRAS G12 mutations. You'd find a few lung cancers, as you see here. But you'd also find some false positives. And these false positives are actually KRAS mutations that are shed from the white blood cells, which we know can happen about 1% of the time. Let's say you use an approach where you looked for one of 813 clinically actionable variants from the OncoKB database. Any of these, you say, look like cancer. You'd find more lung cancers, but you'd also find more false positives. Again, these are mutations present in the white blood cells, which can make you think cancer is present, but actually not. They're false positives. If you instead use the CCGA targeted sequencing approach, filtering out the noise from the white blood cells across 507 genes, you find more than half of the lung cancers are detected, and you can suppress that false positive rate into the range of 2%. Focusing on that 98% specificity rate, here we find across the 3 assays that for early stage curable lung cancer, approximately half of lung cancers are detected. And for advanced lung cancer, approximately 90% of lung cancers can be detected within the blood. You can see that the findings from the training set and the test set, the independent test set, validate. And so, to conclude, this first interim analysis of the CCGA study demonstrates that comprehensive sequencing of the plasma cell-free DNA can generate high-quality data across the entire genome, and it permits non-invasive cancer detection. Assays can detect lung cancer across stages, across histologies, across populations. There are similar sensitivities observed across these 3 sequencing approaches, but they do replicate in an independent test set. And importantly, white blood cell-derived mutations and copy number variations are a major source of false positives, and they must be accounted for if you're going to achieve high specificity and a low false positive rate in such an assay. Together, these results support the promise of using cell-free DNA-based assays to develop an early cancer detection test with high specificity, and further assay and clinical development is ongoing. There's a separate prospective trial enrolling, the STRIVE study, and as well, there remain thousands of patients still on this CCGA study to be analyzed for further optimization and focusing of this assay towards an eventual cancer diagnostic. Thank you.
Thank you very much, Jeff. Very interesting, provocative results. I'm going to ask Dr. David Graham, one of ASCO's experts in this field, to make a few comments.
This is an important first step towards an easier way to detect lung cancer at earlier and hopefully more curable stages. In this first report of a very exciting new methodology, circulating free DNA from a blood draw detected 51% of early-stage lung cancers with an extremely high specificity. In our May presscast, we highlighted a report being presented at this meeting, which unfortunately shows a very poor uptake in our currently approved screening method for lung cancer, that is low-dose CT-based screening. If the promise of this report holds, we could easily see a day when a person could be screened for lung cancer and possibly other cancers simply by going into the regular doctor's office for a blood draw.
So there's a lot of interesting features to this. And Jeff, I wanted to just maybe ask two questions for clarification. One is, of course, so it's not surprising that you might find evidence in the blood for patients with advanced lung cancer. It's encouraging that you find evidence in the blood for patients with early stage lung cancer, but of course the patients in the study already had a diagnosis of lung cancer. So in a sense, the next question is, if you find these mutations in the blood in someone who doesn't have a diagnosis of lung cancer, will you then be able to confirm a diagnosis of lung cancer in those individuals? So I'm assuming that's going to be another part of the research going forward.
So with with greater follow-up, we can follow the non-cancer subjects, some of whom have been called a false positive. But some of those patients have obvious cancer signal in their blood, and already a couple have been found to have cancer with additional follow-up.
All right, so that actually leads me to the second question I was going to ask you, which is that, you sort of characterize these mutations in the normal white blood cells as noise that need to be screened out in order to improve the specificity. But I guess my question is it really noise, or is there some clinical or biological consequence? Why do we have mutations in our white blood cells?
Right, and there will be a presentation on these white blood cell mutations on Tuesday going in more detail. It's true, these are real mutations. They're called clonal hematopoiesis. They can have very real health implications. They don't mean cancer to our knowledge, but that needs more follow-up as well. The biology of clonal hematopoiesis is not really the topic of this investigation, but the fact that it totally complicates such a diagnostic and needs to be accounted for in order to achieve a cancer detection assay, I think is the most important finding here.
Okay, great, thank you.